Good morning. Good morning. Are you able to hear me?
Yes, Dr. Chittalu. Morning. How are you, sir?
I'm fine. How are you?
Good, good.
Okay, so today we're going to look at bipolar disorder. Okay, the lesson for today is bipolar disorder. So without wasting time, I'll just go straight into the lesson. Okay, so at the core of bipolar disorder, you have two different disorders. That is depressive disorder and bipolar itself. Okay, so in other words, we can say we're trying to look at mood disorders. When we talk about depression and talk about bipolar, we're basically talking about mood swings and mood changes. Are we together?
Yes, sir.
Okay, so the types of moods are just depressive and bipolar. The difference is simple. With a depressive mood, we mean someone is feeling low. There's an aspect of sadness. And then when we talk about, for instance, mania, we talk about a person having an elevated mood. Okay. So we're saying if a question comes to say, list at least two types of moods, your answers are supposed to be depressive and bipolar. Are we together?
Yes, sir.
Okay. I'm going to proceed to the next step. Okay, so we're basically going to discuss the two types of moods. Okay, we said there's bipolar and there's depression. So we're going to start with depression. Depression is basically a low mood, feeling of sadness. I'm hearing background. Okay, so I'll continue. I was saying, under depression, we basically talk about people that have a low mood, people that are often sad, or people that are undergoing stressful life events. These are the things that we look at under depression. Okay. So some of the symptoms of depression include cognitive symptoms, affective symptoms, and psychomotor symptoms. So we're saying the basic clinical features of depression are classified as these three, which is cognitive, affective, and psychomotor. Are you able to hear me? Are you able to hear me? Guys, can you get me?
Yes, sir, we can, but kindly, okay, we can.
Okay, so I was
Yes,
saying
yes, sir.
the signs and symptoms of depression are discussed under three components. The first one is cognitive, the second one is affective, and the last one is psychomotor. Okay, so the cognitive symptoms of depression are things like hopelessness, futility, low self-esteem. Okay, so in short, we're saying when somebody begins to have negative thoughts and begins to despair or lose hope, we can call these cognitive symptoms of depression. So what we're saying is that a patient is likely to present hopelessness or low self-esteem or just basically negative thoughts. So this kind of presentation is present only in depression. Are we
Sir,
together?
you are fast.
Okay, I'll slow it down. I'm saying a patient is likely to present with loss of hope, for instance, desperation, a low self-esteem, and any other negative symptom. All these are clinical features of depression. Are you able to hear me? Are you able to hear me?
Yes, sir.
Okay. So number two, under affective,
Yes, sir.
under affective, we are saying the patient is more likely to have a sad feeling. Okay, for instance, people that have undergone life stressful events, such people are likely to feel sad in life, and most of them are unable to feel pleasure, and most of them can easily get irritated, depending on what they are going through in life. So for instance, somebody who just lost a job is likely to have a low mood, is likely to feel sad, and obviously not enjoy a lot of things. They'll often lose their appetite
Sir,
and they'll lose interest. Yes.
we can't get you. Tell Gilbert to turn. Hello?
Yes, I'm able to hear you.
No, we can't get you. When some microphones, tell them to turn off their microphone. Can't get you.
Wait, I'm going to mute everyone. Wait, I'm going to mute everyone.
Yeah, now you can start.
Okay, so I was saying, when you're discussing the symptoms of depression, you look at three basic things, which is cognitive, affective, and psychomotor. Okay, the cognitive symptoms of depression include desperation, loss of hope, futility, poor self-worth, low self-esteem, and any other negative thought. Okay, so a patient presenting with negative thoughts is likely to have depression. Are you able to get me now?
Yes.
Okay, so secondly, we are talking about affectivity. So we are saying a patient with depression is also likely to present with a feeling of sadness and inability to feel pleasure and possibly loss of interest in things that they used to enjoy. And then in addition to that, someone is also likely to present with a loss of appetite. Okay, so irritation, inability to feel pleasure, loss of interest, and the feeling of sadness are affective symptoms of depression.
Yes.
Okay, and then on psychomotor, we're saying someone has a decreased libido. Do you guys still remember the meaning of the word libido?
Yes.
Okay, so we're saying the sexual pleasure is the desire for sexual intercourse is often reduced with the presence of depression. Okay, so we're saying apart from that desire decreasing, depressive patients are also likely to have low energy. Okay, and then they're going to have alterations in the way they sleep. Okay, so there's a sleep disturbance that comes from depression, and then we also have changes in their levels of appetite. So under psychomotor, we're saying decreased sexual drive, decreased levels of energy, sleep disturbances, and appetite changes. All these are clinical features of depression. Which to up tapo? Can we proceed from? Okay.
Yes.
Okay, so the next thing we're going to look at is the comorbidity issues relating to depression, or let's just call them issues relating to depression. What may come out of depression? So the things we're going to discuss now can either be risk factors or they can be complications of depression. Are we together? Can you hear me?
Yes, now we can.
Okay, so I'm saying there are three basic things we're going to look at under comorbidity issues. So this one, I've explained it to say the issues I'm going to talk about now are both risk factors and complications of depression. Okay, the first one is the abuse of alcohol or any other drugs. So how can this be a risk factor? We are saying for somebody who's gotten used to the abuse, or rather to the intake of alcohol or any other drug, okay, the absence of that drug can cause a low mood. There are people that have developed a dependency for alcohol. For instance, they only feel happy and are only joyous after they've taken alcohol. So we are saying the absence of such a substance is going to give them a low mood. They are going to feel sad because now they don't have the substance that they feel gives them happiness. Okay, so that's how come the abusing of alcohol or any other drugs can become a risk factor for depression, because you begin to feel low when you no longer have the drug. And then apart from that, people who are often depressed in life end up abusing drugs or abusing alcohol. Why? Because they've lost interest in things that are they've lost interest in better coping mechanisms. So people like when someone loses a loved one or someone loses employment, they often resort to taking alcohol or abusing drugs or any kind of behavior in that manner. So what we're saying is that the abuse of drugs and alcohol is both a risk factor for depression and a complication with depression. Are we together? Are we together?
I can't get you clearly here. No.
Are you able to get me now?
Pastor, not really. Just try to repeat it on the same slide.
Okay. So what I'm
Yes,
saying,
sir. The network is bad.
Network is bad. We can't get you clearly. Just repeat.
okay. You let me know when you're able to get me clearly. Can you hear me?
Yes, sir.
Yes.
Okay, so I was saying the abuse of alcohol or any other drug is both a risk factor for depression and a complication for depression. But the question is, how can the abuse of drugs or alcohol become a risk factor? So I think for an individual that has a normal life, is not depressed at all, but consistently abuses drugs or alcohol, it means their level of happiness is dependent on the presence of that substance. So should alcohol be taken away, or should they reach a state where they can no longer afford those drugs or that alcohol, they will begin to feel low, they will begin to feel sad. So what we're saying is that the presence of alcohol and drugs may give happiness to someone who's dependent on them. That also means that when you remove those substances, when you take away alcohol from someone who loves drinking it, you are introducing a feeling of sadness in that person. So we're saying depression depression is likely to come to someone who abuses drugs when they take drugs away from that person. Okay. And then the other question can be, how can the abuse of alcohol become a complication? So when somebody is depressed and that disorder is not well handled, it is not managed properly, it could lead one into abusing alcohol and abusing any other drugs. For instance, when someone loses their employment, when someone fails their CA or their end of semester grade 12 results, or someone loses a loved one, such people are likely to resort into the abuse of alcohol or the abuse of any other drug. Guys, okay, so I'm going to continue.
Yes, sir.
So the other point under comorbidity is anxiety. Okay. So anxiety is basically a feeling of fear. It's more of, there's more nervousness in the word anxiety. Someone is anticipating something bad to happen. Okay. So what we're saying is, for someone who's been anticipating or thinking something is going to go wrong, they are likely to feel sad when it goes wrong. Okay, because every day of their life, they are scared something is going to go wrong. So such people are not strong enough. Understand there's a difference between expecting change and knowing something and just being afraid that something will go wrong. Okay, so these people are often low. These people are often not happy. They are most of the time sad. Why? Because they are always thinking something might go wrong. What if I go to write the exam and I fail? Okay, this means someone will not have a happy mood during the exam because they are thinking, I am likely to fail this exam. So I'm saying anxiety can be a predisposing factor for depression. Okay, and then how can anxiety be a complication when depression is not well managed? So this is explained in a way that for a person who's been depressed for a very long time, okay, if depression is not managed, maybe, for instance, they lost a loved one, the only breadwinner passed on, they are afraid that maybe even this one who is taking care of me now is also likely to die. So what will happen is that with the presence of depression, anxiety is going to develop because they'll be saying, since something bad has happened before, it can happen again. Okay, so now someone is going to end up having depression and developing anxiety at the same time. Any questions so far? Any questions so far?
Pastor, again, explanation on
Explain again on anxiety.
yes.
Okay, so I was saying anxiety is a predisposing factor. Someone with anxiety is likely to have depression in a way that, one, they live their life anticipating that something bad is going to happen. Okay, so now if you are expecting something bad to happen, you obviously have a low mood, and a low mood is already a clinical feature for depression. Okay, so for instance, a student is going into the exam room knowing that, or rather thinking, I'm not ready for this exam. I don't think I'll pass this exam. So that feeling of expecting something bad to happen is going to give them a low mood. And when somebody begins to have a low mood, it means they have started developing the symptoms of depression. So that is the manner in which anxiety can be a predisposing factor for depression. And then also anxiety is a complication in a way that people who are depressed, they often have, since they have a low mood because of their depression, they will begin to anticipate more bad things happening in their life. So, for instance, a student loses a sponsor, okay, and then somebody else comes on board to sponsor them. They are already sad from the feeling of losing the first sponsor. Now, that feeling of sadness is going to have them to begin thinking, what if I lose even this sponsor that I have now? So because of what happened some time back, they will begin to feel something bad is likely to happen again. Okay, so we're saying the presence of depression is likely to cause fear of something bad happening for the second time in someone's life. So we're saying anxiety is both a predisposing factor and a complication in depression that is not well managed. Are you able to get me? Are you able to hear me? Guys, can
Yes,
you
sir.
Yes.
Okay.
Yes,
So
yes, sir.
so far I have explained two things, which is number one, alcohol as a predisposing factor, and also alcohol as a complication. And then number two, I have looked at anxiety as a predisposing factor and anxiety as a complication also. Okay.
Sir, I've got a question.
Yes.
Yes, on alcohol abuse as a predisposing factor, I didn't get you clearly. I only heard on the other side for the complication.
Come
So
again.
I need just like a simple explanation. On alcohol, sir, as a predisposing factor, I didn't get you.
Okay, so I explained to say alcohol as a
Are you
predisposing
getting me?
factor. I was saying for an individual who's been, or for an individual who has developed alcohol dependency, it means that they have associated a particular function with the presence or intake of alcohol. For instance, if someone only cracks jokes and feels happy after they've taken alcohol, it means their happiness is dependent on the presence of that substance. So now, when you remove alcohol from their life, they're going to begin to feel sad because their happiness is dependent on that substance. Okay, so what we're saying is that when you take away what someone enjoys most, you're likely to cause depression in them. You're likely to make them feel sad. So for people that have associated the drinking of alcohol to their happiness, it means the absence of alcohol is going to cause them depression. Are we clear on that one? Are we clear on that one?
Yes, sir.
Okay, so thirdly, we're going to look at somatization. Okay, so somatization is basically not so different from anxiety. Okay. So under somatization, it is explained as the development of most of the symptoms of anxiety. However, with somatization, there's also a symptom of pain. Okay. I'm hearing noise in the background. I'm hearing noise in the background. Okay, I will continue. So we're saying under somatization, we look at the development of symptoms of symptoms of anxiety, and then we also look at the expression of pain in someone, and then we also look at fatigue. So when we're discussing somatization or somatic symptoms, we just look at pain as the most common component, and also fatigue. So we're saying, how can pain and fatigue be predisposing factors for depression? Then the other question could be, how can pain and fatigue be a complication of depression? Okay, so pain and fatigue can come to, or rather can contribute to someone developing depression in a way that if someone consistently undergoes life events that cause them pain, they're likely to begin to feel sad. And for instance, I get an injury that never heals. Okay, the injury causes me pain, not only physical pain, but it also begins to cause me psychological pain in a way that physically I can feel the pain from the wound, and also mentally, because the wound is not healing for a long time now, I begin to feel depressed about it. Okay, fatigue, when someone is too weak, okay, someone is too weak, even if they haven't done anything that demands a lot of energy, they still feel weak. So this can also begin to make someone feel low, probably. Why? Because they are beginning to get worried. So we're saying most of the symptoms that are called somatic lead to anxiety. What I mean by this is that when someone has somatization as a disorder, it means they've begun to develop things that can easily cause them anxiety. Okay, so when you have pain that does not go away for a long time, you begin to worry. And in the worries, that's where anxiety comes in. And when you begin to worry, you begin to feel low. When you begin to feel low, that is depression. So we are moving from you having a physical injury. The injury is causing you pain. Now, because the pain has stayed for too long, you begin to worry, which is anxiety. Okay, so when you begin to worry, you stop being happy, you start feeling low. When you start feeling low, it is called depression. So we can see a movement from somatization to anxiety, and from anxiety to alcohol, or to depression, right? So what we are saying is there's a connection in somatization, anxiety, and depression. The connection is simple. Okay, you expect the pain to go away after some time. But if 4 months later, you still experience the pain, you're going to get worried. Maybe I'm never going to walk again. Okay, that anxiety is coming in now. So now, when after 2 more months again, the pain is still there and the worry is there, you begin to feel low. What if I actually become crippled? So that low feeling is going to cause you depression. Okay, so what we're saying is that somatization of pain and fatigue can lead to worrying, and worrying can lead to depression. And that is how come pain and fatigue are predisposing factors in depression. Are we together there?
Yes, sir. Yes, sir.
Okay. So I've talked about the comorbidity issues of depression. I've also talked about the signs and symptoms of depression. So I'm now going to go to more complications or risks of depression. More complications or risks of depression. Okay, so under risks and or rather more complications, we're first looking at suicide. Okay. So the ability of taking one's own life is what is explained as suicide. So we're saying most of the patients who have depression, when it is not managed, they are likely to commit suicide. So here epidemiology tells us 15% of the attempts to commit suicide are actually successful among patients with depression. So we're saying 15% of all those that have tried to commit suicide because of depression have actually succeeded. Only 15%. 85% of the attempts have not succeeded, maybe because someone saved them or for any other reason. But all we know is that 15% of those people who tried to kill themselves due to depression have actually succeeded. Okay. Number two, we're saying the highest risk. Okay. So divorced or single men over the age of 55, most of them are whites. So we're saying men who are above the age of 55, if they are divorced or single, are likely to develop depression, especially among the white people. So I say, if you are a man, you're not married by the age of 55, or you are divorced before the age of 55, you are likely to also develop depression. Okay, so we're saying the numbers or the age is not the same among blacks, but among the whites, the age is 55. Those who are above that age, if they are still single or they are divorced, or maybe they are widowed or something. So such people are also likely to develop depression. So we are saying the risk is higher among the white people than among the blacks. Okay, the other point there is 20 to 25% of people with chronic illnesses have
I
depression.
have a question.
Yes, go ahead.
Do you mean that those people like whites, they don't have something to do because they are because of the divorce or because they are single? Does it mean that they don't have something to do because they become they are depressed?
Okay, so basically, what would cause depression in someone who was once married and the wife passed on or they divorced is number one, a feeling of loneliness. Okay, a feeling of loneliness is one of the things that are likely to cause depression in them. Why? Because for some years you got used to the presence of someone, and then after some time now you begin to live alone. You have the whole house to yourself. Okay, and people get used. When I'm working to provide for someone. So now there's no one to provide for. You have the money, but there's no one to make you happy. Okay, so now what will happen here is most of them will end up abusing alcohol, or they will end up doing maybe abusing drugs or any other activity that may be termed deviant in society, because maybe their source of happiness is no longer there. So what we're saying is that them losing a wife, maybe because of death or because of divorce, is not directly linked to having depression, but it is linked with the symptoms of depression. Are we together? See, when we talk about depression and maybe encourage people to go for counseling, we don't mean they actually have depression as a disorder. Depression begins from something as simple as a feeling of sadness. Okay, if something happened and you are feeling sad about it, you need to seek help, because depression begins from something as simple as that, just a low feeling. Okay, even anxiety begins from something as simple as, where will I get the money to parent this month? It can begin from something that simple. So if within your head you are considering how you will parent and you cannot find the solution, the probability is high that you're going to feel low, you're going to get worried over time. So what causes depression in the whites, in this case, is not a direct link with what happened in their life, but the event that took place in their life is going to be linked to some of the symptoms of depression. That is what happens among them. It's not that they're not strong or they don't have what to do. It's just that to our friends, a feeling of or let me say, a low feeling is a big problem for them. And that is how come there's a myth that says black people don't do therapy. Someone came up with that saying because they've seen that over a simple thing such as just feeling low, a white man will go and see a counselor. Why? Because they also understand the statistics that something as simple as feeling low can actually lead to depression. Okay. So next we're saying 20 to 25% of people with any other chronic illness have depression. What is a chronic illness in this case? We're talking about an illness that has lasted for a long time, an illness that has stayed for too long. Overstayed is welcome. The acute illnesses are those that you can just have today, and within a short period of time you become okay. But for instance, someone with diabetes mellitus, someone with a heart attack, okay, these things can, even just asthma, these things come, you can develop it today, and 15 years later, 20 years later, you still have it. So now the presence of that disease can actually cause someone to begin to develop depression. Okay. Are you able to hear me?
Yes, sir. Yes, sir.
Yes.
Yes, sir.
Okay, so I'll continue from the risks. We're not talking about the treatment of depression. Okay. So when you're talking about the treatment of depression, you simply give antidepressant medications. These are the things that are helpful in the treatment of depression. Okay, so when when somebody is undergoing this, you give them antidepressants. I'll send you later on a document.
Sir,
Mr. Ngoma's phone.
Sir, before you go in further, I have a question. Sorry, I have a question before you go in further.
Yes, what's the question?
Yes, sir. Before we go to treatment, are there any investigation that we can do to a depressed patient?
It's simple. The presentation itself will give you investigations. The only other thing you need to find out is for how many stressful events has someone undergone, and then what are their current coping mechanisms. For instance, someone tells you this happened to me in this period, or maybe in this year. You can find out from them in which maybe what did you try to do? How did you try to cope up with what happened at that time? Okay, what are your current defense mechanisms? So you just find out these few things. Are you able to hear me?
so, sir, you mean in short, investigations are clinically, isn't it?
So most of the investigations are not clinical. While you're taking history, you can do your investigations there. Okay.
All right.
So we're saying during history taking, you're also going to find out from the last time you got depressed, did you see a doctor? Okay, what did they tell you? What medication did they give you? So we said when we're learning about history taking, we said that you consider your past medical history. Okay, you also consider your past psychiatric history. So if you've already taken these things into consideration, it means you know the medication that they are taking now. Okay, if at all they've taken any. So some of them, maybe they tried to take antidepressants, but they developed tolerance for the drug they were taking. Okay. So now you can choose a different antidepressant, either depending on the choice of the patient, or depending on the weight of the patient, or depending on your experience as a practitioner. Are we together? So most of the investigations for depression are actually handled during history taking. You can find out all the things that you're looking for during history taking. So I was saying, I will send you a document using Mr. Ngoma or Mr. Manza's phone on WhatsApp, where I'll explain the actual antidepressants that you're supposed to give and the dose. Are we together?
Yes, sir.
Yes, sir.
Okay.
Just to help, sir.
Okay. So,
Sir,
yes.
sir, are you there?
Yes.
I'm sorry. I know I just came in late. I want to know where depression is coming in when you talk about bipolar, acute bipolar, like we are talking about. Where is depression coming in here? What is it all about? Is it one of the...
We're talking about mood disorders. Okay. And under mood disorders, we have bipolar and we have depression.
No, okay.
Yes. So depression is simply one of those disorders that can cause a change in mood. Okay.
Nice one.
So it means when you're depressed, you're going to have a low mood. But in bipolar, we talk about mania. Okay, mania, we're discussing someone who has an elevated mood, excessive happiness. Okay. So I was saying the document I will send online is going to consist of all the antidepressants that are common here in Zambia and maybe elsewhere, and then even the dose of the antidepressant. So I was saying, if a patient is not reactive to this antidepressant, you can take a different antidepressant and give it to them, maybe depending on your experience as a practitioner, which one is effective in your experience, or depending on the weight of the patient, or depending on the choice. Pardon? I didn't hear the question. Okay, I'll continue. So the other one that you provide is psychotherapy, and then you provide counseling for such people. Okay, sometimes they need to do exercises. Okay, and then they need to find a friend. Even group therapies is helpful during counseling. Okay, or for someone with depression, maybe create a group in which people come with different reasons, especially people that are depressed. Maybe they are depressed from different sources. Maybe this one is because they lost a loved one. This one is because they lost a job. This one is because they lost a child. Okay, such people can be brought together to share their own experiences so that they can learn from one another. So we're saying psychotherapy is very effective. Okay, counseling is very effective. Group therapy is very effective, and depressant medications are also effective. So basically, that's what you consider under treatment for depression. Jamfika. Come again. Guys, are you there?
Yes, sir.
we are here.
Sir, yes, sir. It's no question. Let's continue.
The network is bad. I'm not able to hear you. Okay, guys, so let's do this. Since we've talked about depression now, I'm going to make an audio due to
No,
time.
so I'm saying that you are too fast. Repeat on treatment of depression, sir. Repeat.
On the treatment of depression, I only said
Yes, sir.
you give antidepressants. So I'm going to explain SSRI using the document that I will send to you on WhatsApp. So we're saying the effective treatments are antidepressants, counseling, psychotherapy, okay, and also group therapy. These are the effective forms of treatment for depression. Now, Mumfa. So I'm saying,
no, sir.
Yes, yes.
The document that you're going to send, is it going to comprise with even, for example, talk about antidepressant medications? Are you going to list down how?
That is the purpose of sending that document, so that I can explain which antidepressants can you give. What is the
sir, you're too harsh on answering, sir. I just wanted the friendly one, eh?
Oh, I have less than a minute before the end of the session.
All right, sir.
So this is control. After 40 minutes, end. Now, empathize one.
Sir, continue.
Okay, so
yes.
I was saying a session only takes 40 minutes, and as far as I'm concerned, I think I've gone to more than 40 minutes. So my session is going to end anytime soon. But you guys, tomorrow I'll still get back to you so that we can finish up with the bipolar side of mood disorders. Okay.
Okay, sir. Just say Marituma.
So friend at the academic group.
No, that's okay. Today, miss a few. You can take that again.
I'll ask Mr. Ngoma to send it again.
Okay, sir. We appreciate
it. Guys. What's up? We can end the session.
No questions, sir. Pick up a question.
Nice. I want to stop recording so that I can take the question.